Hello, my name is Gabriela-Mariana, and I'm an academic scholar in psychology and also a clinical psychologist and a PhD student in neuroscience. My current research focuses on clinical neuroscience, and today I'm going to show you a little part of my research focusing on particularities and electrophysiological and psychoneurological assessment of mild traumatic brain injury. The mild traumatic brain injury can generally be defined as an injury caused by acceleration, deceleration, or compression forces that produce a period of unconsciousness for 20 minutes without intracranial complications. Despite its frequency, there is no uniform agreement on the nature of the disease. We have no standard diagnosis test, and also we don't have an agreement on the acute need of hospitalization. Traditionally, mild traumatic brain injury have been considered insignificant, as the symptoms resolve spontaneously after a few days. This idea is facing still a growing need for reanalysis, as we will see in this study. Despite progress in demonstrating the underlying neuropathology in mTBI, considerable disagreement persists in neuropsychology on the effects of mTBI and also the assessment tools. Over 80% of TBIs are mTBIs, so the prevalence of the mild form is pretty high in the general picture of brain injuries. While concussion symptoms resolve within a few weeks or days, some individuals may have persistence of symptoms for 3 months or more. These were referred as post-concussive syndrome. A long-standing controversy surrounding this PCS concerns the nature of its etiology and the degree to which psychological and organic factors involving brain dysfunction are responsible. And this debate has been called psychogenesis versus physiogenesis of the PCS. PCS has been very much debated in literature due to conflicting findings about symptom duration, the absence of objective neurophysiological findings, inconsistencies in measurements, poorly understood etiology, or methodological problems. Depending on the definition and the method, between 29 and 90% of patients experience PCS after the traumatic event. Now, regarding the diagnosis problem, we have these two diagnosis systems. And when we had DSM-4 and ICD-10, we had some criteria for post-concussional syndrome, but there were also clear differences. One way, the ICD referred to a syndrome, the DSM referred to a disorder. But most importantly, the DSM required evidence from neuropsychological testing or quantified cognitive assessment of difficulty in the cognitive domain, which was not the case of the ICD-10. Interestingly, over the last 10 years, research has shown that PCS-like symptoms are generally not related to milder traumatic brain injury, but instead are associated with accompanying acute post-traumatic stress disorder, chronic pain, depression, or anxiety disorders, so that studies had identified bigger percent associated with these disorders than actually with mTBI disorders, like 32% in mTBI and over 50% in most of the other disorders. And these results are consistent with existing literature, showing that the PCS signs and symptoms are not unique to concussion. This impacted the trend within neuropsychology research that should now have to focus on specific outcome following mTBI and not on the post-concussion syndrome. As we previously mentioned, the research predominant findings are showing usually full cognitive recovery within days to weeks of the injury. If cognitive difficulties persist, the cause might be thought in other factors such as depression, PTSD, chronic pain, and psychological factors. The validity of association of PCS with the mTBI is questioned. In the latest version of the DSM, in the DSM-5, where there is no longer a category for post-concussional disorder, but a new spectrum known as the neurocognitive disorders. And here we have the both diagnosis guide, DSM-5 versus ICD-11, where we have the mild neurocognitive disorder or major neurocognitive disorder due to mTBI on one hand, and on the other hand, in the ICD-11, we have not the PCS individually included, but a synonym like a mild neurocognitive disorder. The picture overall doesn't look very clear at present, as both clinical and research evidence to guide diagnosis of PCS are fraught with inconsistencies. This is the state of the art while we are talking about particularities of neuropsychological assessment in this mTBI diagnosis. Thus, the current challenge of concussion diagnosis have to refer to inconsistent picture of the disorder, having no golden standard diagnosis test, no established battery of objective or subjective measures, and still no biomarkers of this pathology. We can also consider that even if recovery is frequent, complete within a couple of months since injury, in some cases there are sequelae that impact the executive functions or other brain functionality as well. Given the case, multiple evaluation tools are recommended, like combining self-reported scales with structured interviews, checklists, and neuropsychological assessment. Thus, we can increase the specificity and sensitivity of the mTBI identification. The usefulness of a test to diagnose a disease is usually described by terms of sensitivity, specificity, positive predictive value, and negative predictive value. These measures describe how well the test identify people who actually have the disease or who have not the disease. However, interest is raised also by predictive values, positive or negatives. In order to increase the predictive value, we need to stop looking only at the PCS and to mix the objective and subjective measures in a complex evaluation tool. And here we summarize tools used in literature for one of mTBI domain, like mental fatigue, and the symptoms are marked within the instruments and the equipment involved when the case, as well as the team-specific measures. This could be done for every of the mTBI domain. This proposal is also consistent with a recent review of screening tools for the diagnosis of mTBI conducted by Park and Co. that concluded that it is not recommended to diagnose mTBI or to monitor the recovery solely with cognitive and balance evaluation, but to use these measures in conjunction with clinical examinations and the symptom checklist. Neuropsychological testing, which we shortly wrote NPT, is one of several tools in the assessment of an individual with concussion, but does not independently determine if he or she has experienced a concussion or else. So literature conveys on two main reasons for neuropsychological assessment of mTBI: to determine the presence of cognitive symptoms for early diagnosis and to monitor recovery. Neuropsychological testing is a key component of the recommended multidimensional approach to evaluate individuals affected by concussion. However, researchers recommend that neurocognitive testing should not be used as the sole basis for diagnosing concussion. More than a contribution to diagnostic, the neuropsychological testing of mTBI patients in the acute setting has also predictive value. It has been suggesting this to identify patients at high risk for prolonged cognitive deficits. However, we still need to further study to validate this conclusion. Some other findings refer to neuropsychological markers found out by these assessments, like we see here: visual working memory, higher score for delayed memory index, some personality dimension like psychoticism as a predictor for mTBI symptoms, and so on. We can conclude that patients with mTBI often develop a constellation of physical, cognitive, emotional symptoms that are most widely known as the post-concussion syndrome, but should not necessarily be associated with this specific syndrome. Rather, we should think the assessment in terms of neurocognitive symptoms and evaluate at least the 4 key domains in the chronic neuropsychological impairment after mTBI. like higher order attention, executive function, episodic memory, and speed of information processing. Literature usually agreed that neuropsychological assessment of children and young adolescents imposes certain unique demands on the examiner. Also, studies show that head trauma during development can be severely disruptive, mainly impacting plasticity. So we have to give special attention when you're assessing youth population or pediatric population. Neuropsychological testing has advantages but also limitations and factors that affect the resulting scores and interpretation. And here are two reviews that stated this. And also one actual concern regarding the test score is that they may reflect the overall status of the individual, but because they are designed to assess brain function, the inclusion of symptom-related error into the test score interferes with the psychometric accuracy of the test, eventually with the test's ability to accurately measure the brain function. And this could be an important limitation. We have this new generation of computer-raised NCATs, like objective measures of brain function, with their advantages and disadvantages, and also question psychometric properties and clinical utility. Anyway, the literature is confirming the validity of 4 NCATs commonly used for both clinical and research purposes that we have here stated at the end of the slide. One of them is a Cox-State battery, which is rapid, reliable, simple, and sensitive, and investigate several cognitive domains, also having a brief form with constant validity and sensitivity demonstrated in a wide scientific literature. The advantages are also formed around the minutes for completion, also availability in Romanian language, high sensitivity and specificity, and also the big and strong correlation with conventional neuropsychological measures. To complete the picture of the objective measures, we propose the neurophysiological physiological measures like QEEG and ERPs. The QEEG techniques are using the electric signal read by the electroencephalogram to make computations resulting in brain maps that could be compared with normative databases. QEEG proved efficiency in detecting change in brain electrical processing following concussion and after behavior deficits have disappeared. These findings continue to point out differences that suggest abnormalities in brain functions despite the absence of the behavioral signs and symptoms. And those were confirmed in literature, like reporting similar results even after 45 days post-injury. Also, a paper published in April 2021 supports the use of QEEG as an efficient and cost-effective screening tool, especially when visual EEG inspection provides no cues of possible concussion. It is stated that QEEG shows sensitivity and specificity both in acute and convalescent setting. And here are some EEG patterns found in mTBI by Thornton and Thatcher. These findings may have a positive impact on treatment design, especially when choosing to apply neuroregulation techniques like EEG neurofeedback, which is designed by QEEG waveform differences in absolute and relative power found by these studies. The event-related potentials, ERPs, are EEG partitions that are time-locked to a stimulus onset. Time locking means recording only one part of the EEG waveform that follows the word, sound, or picture stimulus. Upon onset, the EEG desynchronizes and produces an electrical waveform composed of a series of positive and negative voltage fluctuations that can differ in their amplitude and latency. This is an interval of approximately 500 to 1200 milliseconds before it returns to the baseline EEG signal. Research shows encouraging results in using these cost-effective measurements of brain activity, showing strong association with functional findings from fMRI, imaging, near-infrared, and PET techniques. One big advantage is the temporal resolution of the information, which is very high. Some findings in the ERP research indicated relationship between brain behavior measures in concussed versus non-concussed people. Also some components like P300 of P300B, which are smaller in children, adolescents, and adults with concussion. One other characteristic, it's similar to QEEG studies. In ERP studies, we have these recorded differences that may continue even in the absence of other indicators of concussive injury, behavioral or somatic requirements. And neurocognitive functioning was found to be altered in mTBI teenage population while assessing some components like N2B, P300, and mismatch negativity. Also, the N2B latency correlated with the number of days since injury, making this last component a possible marker of the recovery process. We advise one should be careful with the interpretation of these results in the ERP studies, as they are true for a relatively small set of tasks that assess a limited array of cognitive abilities. This is why a combined assessment would ensure more precision and validity. Even if most of the studies about neuropsychological testing for diagnosis of mTBI are usually reporting administration within 72 hours of the injury, some objective measure could be used even after, like QEEG and ERPs. Even if the differences found are useful for grouping subjects in symptom clusters, there is still a lot of individual variability and lack of stability in some of the measured variables. This is why we should use the neuropsychological tests to characterize functions in order to contribute to diagnosis and not to make the diagnosis itself. Given the peculiarities of neuropsychological functioning after the mTBI highlighted in this study, we conclude that more research is needed to define a post-concussion phenotype. We also propose an assessment approach with objective and standardized measures to provide the best sensitivity, specificity, and predictive value for detecting possible cognitive and functional deficits in mild traumatic brain injury. Thank you for your attention.